So our third and final speaker is Tom Lewis, who's a consultant microbiologist from North Devon. And the reason I asked Tom, because we've worked together on a couple of individual patients who have had very complex needs in terms of management of their UTIs, and it's thrown up a lot of interesting tensions between the routine microbiological assessment and the clinical care of people with recurrent complex UTIs. So Tom, be interested to share your insight.
Thanks very much, and thanks very much for inviting me. So I know this place is the GMEX. So the GMEX is was at the heart of the Manchester music scene in the mid-80s. This is a quasi-religious experience for me to be on the same stage once trod by the Smiths and the Happy Mondays. So I hope I can provide a small percentage of their entertainment. So this, I'm going to talk about a couple of cases really, and sort of how I approach these as a microbiologist now, and really the conclusion is going to be that we can't do this alone in the lab, and we need to work with the urologists to do this. And I guess I'm here because I work with a very good urological team in North Devon, so some close working with the surgeons and some excellent clinical nurse specialists as well, and now further afield as well. So I was going to talk about a couple of patients. So I was going to have supposed to be a photo of Sarah actually, but it disappeared off my phone. And it's probably good because she was going to be a success story, but I'm not sure she is an entire success story. But she's a 27-year-old woman that developed Fowler's syndrome last year, so has been intermittently self-catheterizing over the last 12 months, and has been getting infections every 3 to 4 weeks with increasingly resistant pathogens. And so I came across her 2 weeks ago now with virtually impossible to treat infection. And it's interesting how she's perceived by clinicians. So she has gone from a normal life where she was riding horses and working full-time as a carer to basically having a socially stigmatized disease. So it's offensive urine, so difficult to go out with that. Unable to work, so she's been off work for 6 months now, not riding horses, and generally having a fairly miserable life. And yet she's seen as a problem patient because she doesn't really fit our paradigms of infection, and we can't really do anything to help her in a way that's simple anyway. So she's been labelled as not quite right up top, or generally, I mean, she is quite miserable, and she just spends most of her life in tears, but it's not surprising because her life has been turned upside down. So this shows what we see in the lab for her. So again, this shows some of the problems, I think. So there's a Pseudomonas here and an Enterococcus species here. So already you see this is a mixed infection. So this is repeatedly growing these two isolates with two relatively non-pathogenic organisms. There's certainly no E. coli in here. And most labs, or certainly a lot of labs, would chuck this out as a mixed growth and wouldn't do any further work on it. This is what it looks like on a mixed sensitivity plate. So this is what we do for all of our isolates. Now we put up 12 antibiotic discs on all our cultures, and you can see, as you'd expect, the green stuff here. I think it's green. I'm colourblind. This is greens that look at green to you. Is the Pseudomonas, and as you'd expect, it's resistant to nearly everything apart from gentamicin, carbapenems, and tazocin. It's resistant to ciprofloxacin, which is obviously the only oral agent for a Pseudomonas. I don't know whether you can see the Enterococcus here. So the Enterococcus is behind the Pseudomonas, so it'll be all over these plates. But you can see it, as you'd expect, growing into the gentamicin disc, but it's also growing into the meropenem and tazocin disc. It's beta-lactam resistance. So the only actual option here, if you did a purity plate off here, the only option here is vancomycin to treat this, or the only easy option. So this is a difficult to treat infection. So how do we approach these patients? I don't know who was in the talk earlier about UTI, which was a nice warm-up. Talked about most of what I'm going to talk about, really. But these are a very difficult group of patients. So 2% of women probably get these fairly intractable infections for which there is no really good evidence base on how to manage them. So we're into a world where we're slightly making it up. So I'm going to talk to you about the patient that I've been working with Professor Pickard on. And this is our approach. This is sort of how I have been trying to make sense of some of the conflicting data and turning that into a sort of practical management plan for this woman. So this is a 56-year-old woman who had an enterocystoplasty a few years ago, or decades ago now actually, and has been getting frequent and disabling infections ever since. So this shows her microbiology over the last 5 years. So you don't really need to know what all these organisms are, but each dot here is a different bug. So each line is a different species, and you can see. So she mainly gets infections with this stuff down here. So there's an E. coli in there. There's a non-aeruginosa pseudomonad. There's a strep, which isn't an enterococcus. They're her major problems. And again, it's interesting just to think they're not particularly pathogenic. They're often in mixtures, and most labs would throw them out. But then there's also a load of other stuff which is completely unpredictable and comes left field, really. So there was an Eromonas in there once, a Stenotrophomonas, all sorts of stuff, really completely unpredictable. Who knows what it all means? The talk from Vanya Gant, I thought earlier, really highlighted the fact that we don't really understand anything about the microbiology of the bladder beyond Cass's criteria, which is only appropriate for a very small number of patients, and certainly not for these sort of people. So the first thing I think we'd say is, well, let's focus on what's important to the patient. So she would say, well, she said, I don't want to have infections at all, but she would say that the main thing that she wants is that when she does get an infection, she wants the time to the next infection to be as long as possible. So when I started in the trust about 5 years ago, she was in the hospital. She'd been in for 4 weeks on IV antibiotics, and this was just a recurring theme, and life was pretty miserable. So we said, well, let's start again. Let's just stop giving you IV antibiotics. Let's start a symptom diary, and you can be in control of your UTIs. You tell us when you're getting a UTI, and then we'll have a think about what we're going to do. But the first thing we want you to do is to keep a symptom diary and track what's going on. And so she's done that ever since, really. And this just shows the time between her infections over the last 5 years. And as you can see, we've made no progress whatsoever. So, in fact, things may have even got worse. So this is the time between infections, and it's remained fairly consistently at 2 to 3 weeks. And we've tried quite a lot of things. So we've tried prolonged IV antibiotics, so ceftazidime, adenine through rifampicin, with the hope it might work better on intracellular bacteria. I think she's had some azithromycin with a similar, might work better on biofilms. She's tried prophylaxis, makes things worse. We've tried intravesicular gentamicin, she found that very painful. Hippuric acid hasn't really done anything. She's had cystostatin ialuril, maybe has had some benefits, but probably not. Basically, whatever we do hasn't really worked, and actually, the more we did, the more resistance we ran into. So the secondary thing she would say is that if she has an infection, she wants the duration of symptoms to be as short as possible, and I think we've certainly had a fairly major effect here. So now when she gets an infection, we can get her back to normal within a few days. And if you look at the beginning, this was, we were up to, well, we weren't really ever making it better, to be honest. So how have we done that? So I think we start antibiotics much earlier after the onset of symptoms. So before we were sort of 4 or 5 days of let's hope it all goes away, or just that sort of wishful thinking of don't come and bother us, really. Whereas now she makes the call when she's got a UTI, and she starts antibiotics on the day or the day after. We're much better at getting antibiotics right first time. So this is the number of antibiotics used each episode. So again, beginning we were using up to 7 antibiotics in an episode, whereas now we only use one antibiotic in each episode. And this, I think, so this isn't actually her plate, but it's sort of the sort of stuff that hers look like, actually. So this shows the problems with managing UTI in the lab. So this is a mixed culture. So there's at least 3 organisms on here. There's probably a Pseudomonas here. There's probably a coliform that's growing up to the gentamicin disc here. There's probably a strep here around the Cipro disc. And it's quite difficult to know what any of that means, really. So the standard interpretation of that is a mixed contaminated culture, which is probably true for them. Most part of what we get in the lab, and we do get an awful lot of dross in the lab. So dipsticks, catheter urine is the classic, and that's what you'll grow, and it's utterly meaningless. But then you have these complex patients where it's actually probably highly relevant. And I think as a microbiologist, I'd say I don't know what it means, but I do know I can say some things. So I can say that If she was septic, I'd use tazocin or meropenem. I wouldn't touch anything else. If I was looking for an oral option, then Cipro is probably the best bet, although just noting that it grows into nalidixic acid here. So as Matt was talking about, this is a sign of a first step in the GRA mutation. So probably want to be avoiding that. But you can start making, I think there's everything you need to know to make a clinical interpretation on this mixed culture plate. And you don't need to do any sort of gold standard microbiology now to work up exactly what all of these organisms are and exactly what their resistance mechanisms are to make some sensible clinical calls. So on the back of that, we've changed our lab processing. It's actually interesting, again, what Vanya Grant was saying earlier about flow cytometry. We got rid of our flow cytometer because it saved us £20,000 a year, and we felt it made absolutely no difference to clinical decision making and was actually making us make bad clinical calls. So we got rid of the flow cytometer, and we put up we had a bit of a drive on getting higher quality specimens into the lab, so we started refusing to process anything that just had dipstick data on, and said, so we're getting higher quality specimens, we can do more work on them. So we were much better at getting specimens in on the day they were taken. So this top graph just shows a sort of step change here in that we started processing things on the same day. So that's mainly by getting the lab staff in until 10 o'clock at night, 7 days a week. We let them go home for an hour or two in between, but they're quite cheap. And then we got, this is the percent, this is probably more, as important, the percentage of urine results we release on the day after receipt. So this includes mixed cultures. So we are much better now at getting something meaningful out to a clinician within 24 hours. And actually, if you look at a urine culture plate, you can read it within 6 hours. So you can start getting a feel for what antibiotics you're going to want to use potentially within 6 hours. Just to remind you, this is what your gut looks like after you've given antibiotics. They are quite bad for you, and we don't quite know what's going to happen to you if you do this to your gut, but we do know you'll probably become fat and you might get cancer. So it's something that we should treat antibiotic therapy with a lot of caution. And as a doctor, I would not want me or my children to have antibiotics, and I think we poorly consent patients for what we do to them. So I think when we are interpreting these mixed cultures, we have to bear in mind that there is quite a potential for doing harm if we don't understand why we're doing it, really. And that's why we can only do it in the collaboration with you. So we also have moved away from course lengths. I'm never a big fan of course lengths, really. I mean, if you look at the data on course length, so 3 days is probably adequate for most people, but actually 1 day, single dose works for 70% of people. And then there's some people who need longer, who just don't get better. So I tend to go on symptoms, and so what we say to this lady is that you basically continue your antibiotics until 24 hours after you feel better, and then just stop. And I think that the more you look across microbiology, the more that is true. So pneumonia, if you're better after 3 days, even if you've got a pneumococcus in your blood, you can stop the antibiotics safely. I think we need to go back to clinical judgment much more and never look at the CRP ever again. So she says she wants to minimise her exposure to antibiotics. She sort of says that. I make her say that, really. And we've had some effect there. So what we have done there is we've moved away from a lot of broad-spectrum antibiotics. So we use a lot of linezolid and tazocin and gentamicin and ceftazidime and some carbapenems at the beginning. We now really only use amoxicillin, cefalexin, nitrofurantoin, and a little bit of tazocin. And that's really because we understand her very, very well now. And we know that she's got a complex allergy history, so she can't tolerate ceftazidime or ertapenem. She can manage meropenem, and she can manage the beta-lactams. Not many people would give somebody who's allergic to ceftazidime amoxicillin. But we know she's fine, so we feel confident in doing that. And so we give much shorter antibiotic courses, mainly because we go on symptoms rather than prescribe course lengths. What she really hates is IV antibiotics, and we very rarely give IV antibiotics now, and that's because we know her well and we can give her a mox, kef, or nit. So our summary is, so we've missed our primary goal, which was to reduce her infections. We've tried quite a lot of things. We've delivered against our secondary and quaternary goals, mainly by cutting out the middleman, actually. So the GP, you need to have the GP on board to do this, and they're more than happy to just basically let us get on with it. And basically this is achieved really through cooperation with the patients. Just to go one beyond Douglas Adams here, we didn't cause conflict with our quinary goal. So I had to look up what that was. But anyway, I think early use of antibiotics, a good dose, actually reduces the potential for emergence of resistance. And just for her, just when I was writing this talk, I was reflecting the thing that she actually wants is to live a normal life. That's what all patients say, I want to be normal. And for her, it was helping her understand what was going to be normal for her was actually the most important first step. So to realise she was going to have to live with infections was important. And she's now playing tennis after her tendon rupture from her quinolane has got better and her ototoxicity from her gentamicin use. So she's come through everything we've thrown at her. So my narrow microbiological conclusions, so early culture-guided therapy may be beneficial in complex patients. Laboratories need to be active partners in interpreting complex results. Resistance may be minimised by earlier treatment, and I think the problems arise from delayed, half-hearted treatment with poor antibiotic choices. I think, I've found some of this quite profound. I think you have to realise there is a hierarchy of purpose, and it may not be possible to achieve all of these, but we need to talk to our patients better about honestly about benefits and harms of different options. And I think that's what our role as doctors is. It's a guide. And algorithms work very well for most people, and we don't need to be involved in the algorithmic care of simple things, but we are here to guide people through the complex wilderness of evidence-less medicine. And then we have to make sure that we actually design systems that allow that to happen. Thank you very much.
Thank you very much, Tom. That's obviously, we've been through the spectrum of knowing the genetics of E. coli, some algorithms for common things, and then lastly from Tom, a change of tack of how to deal with these complex patients who come through our care and whose care is frequently very fragmented and therefore not particularly good. So any questions particularly for Tom about that type of patient who I'm sure we all have in our clinic load? Yes.
There have been a couple of references to intracellular bacteria, and I wonder if that's a real entity or not and what we should be doing about it.
Well, you can see them on the confocal microscope, so I'm pretty sure they're there. What they really mean is, I think we don't know, do we? I've always been quite persuaded by some of the work that comes out of Malone Lee's lab in London. It's quite maverick in some ways, but I think I buy the idea that you have to give people some high-dose antibiotics for a while to treat these infections. So I basically split these patients into two. I say there's some people who are going to go onto this sort of expectant early start, so self-start therapy, and then there's some people who get recurrent infections where you can give them high-dose antibiotics for 3 to 6 months, which might be what prophylaxis is doing, actually. So the difference between high-dose and prophylaxis isn't a huge difference, is it? But try and avoid those sort of low-dose things which just select for resistance and treat them with cefalexin and azithromycin or something. I don't know. I'm sure the microbiologists I know there are microbiologists that think I'm crazy for doing that, but that's my logic. It's because there are almost certainly intracellular bacteria around which may be doing something.
Any more questions for Tom particularly? Okay, thank you very much.